Welcome to Let's Get Curious, the podcast for women and mothers seeking connection, support, and inspiration. We are friends, mothers, and therapists. Lori, a physical therapist, and Dorothy, a speech and language therapist. Together, we share our personal stories, including IVF, birth experiences, and navigating children's learning difficulties. Through our discussions, we uncover profound lessons for personal growth. Join us on this journey of curiosity, compassion, and empowerment. Welcome to Let's Get Curious. Hello, everyone. Dee Dee and I are back today, and today we have a guest with us, and her name is Kelley Carter. She is a speech language pathologist with over 20 years of experience. She earned her master's degree from California State University, Northridge, and has worked across rehabilitation hospitals, skilled nursing facilities, schools, early intervention, outpatient clinics, and home health. Kelley specializes in feeding disorders, speech and language development, articulation, apraxia, phonological delays, oral motor myofunctional therapy, fluency, and voice. She has advanced training in cranial nerve dysfunction, autonomic nervous system regulation, the tummy time method, and pre and post frenectomy therapy, with a focus on supporting airway health, oral development, sensory regulation, and social interaction beginning in infancy. In 2014, she founded Speak Easy Therapy to provide high quality functional therapy that supports children and families through a whole person approach. Welcome, Kelley.
Hi.
Hi. So before we dive in to what we're going to be talking about today, I would love for you to go in and explain to us a bit, Kel, of how you got interested in speech therapy. And when I met you back in the Bay. It always circles back to the Bay, ladies. We're all
It does.
It does. I was a physical therapist working with you in skilled nursing. And that's how we got to know each other. And I don't know if I ever told you this, Dorothy, but Kelley always had her license plate that said Speak Easy, which is now her business. But
wow,
kid you not, we'd be out after work doing our thing, happy hour, whatever, hiking. And Kel's like, someday I'm going to have my own clinics. And here we are. Here we are.
Wow.
Here we
Talk
are.
about manifesting, Kelley. Way to
Right?
go.
It
I
has
need
happened.
to do that.
It was a vision a long time ago. And so obviously we've all gone off in different directions. Kids, life has taken us all 20 different directions. And now here we are back. So I would love for you to just explain how you got into speech therapy. Obviously, I know you from the geriatric world, but now your focus is all on pediatrics. So kind of catch us up to speed.
So I just felt like with geriatrics, I was doing the same thing over and over again, and I just needed a change. So, as you know me, I'm very type A. So I just shifted gears from adults to babies or kids and just grew that skill set. And so finally, when Jason became a police officer, I could step out of skilled nursing and do something else insurance wise, right? That I could not have to worry about health insurance. So I started doing a early intervention, and I kept having families ask me, can you keep seeing my kid after they turn 3? And so actually, really in the beginning, I said, yes, but I'm never going to have a storefront or people working for me because I didn't know how to do that. But the need just kept growing and growing and growing. And so I felt like I couldn't just say no. So I grew to 4 clinics in 10 years.
Wow.
So that's that. But I just love the kids because you're blessing them and those families from a very early age, giving them gifts for development and growth that can help them the rest of their lives, as well as supporting the families through those hard times and giving them strategies to maximize their life as well as their child's life. So that's really my passion and why I now focus and on infancy, because I'm seeing issues from infancy that if it's not addressed, now they come in at 2 or 4, and when I ask the parent, when did this start, and ask them some of those questions, they're saying, yes, it started from breast or bottle feeding. So now I'm going all the way back to babies, trying to make a difference for the rest of their lives. So that's kind of how that happened. And then the myofunctional piece was just that bigger picture that I felt like was missing earlier in my career. And it just gave me that aha moment in big scale, because it's major things that if they're not seen can delay progress or just not give them that maximized progress.
Wonderful. Well, and that's what we're going to dive into today is the myofunctional therapy piece, because as everybody heard, Kelley, list of what you have been trained in and certified in is long and amazing and beautiful. But for today's purpose of the podcast, we're going to be talking about myofunctional therapy. So can you explain to us, Kel, a bit more of what that is?
So basically, it's looking at breathing, posture, and basically oral function. So really, your tongue should rest in your palate at all times when you're not talking. So at sleep and everything, you should have nasal breathing, mouth closed, tongue resting in the palate. There's a lot of kids that are not doing that. And again, I'm seeing that from infancy. So if your tongue isn't resting in the palate at all times, eventually the palate gets higher and higher. The tongue can't fit up there. And those kids have that open mouth posture, which also affects dentition, airway, because if the airway is narrow, the breathing is an issue. And that's the snoring, but it also changes the complete structure of the face, the jaw, everything. So really getting that tongue resting in the palate as early as possible to promote that airway and the facial structure. But then also looking at how are they breathing? Are they nasal breathing, mouth breathing? And if they're mouth breathing, why? Even teaching a child who can nasal breathe but never did, that's a whole skill in itself, because it's a skill you have to learn. And then posture too. So that head down posture is going to promote mouth open versus upright posture, which also helps with diaphragmatic breathing and all of that. And then another aspect of orofacial myology is proper swallow. So your tongue should rest here, but when you swallow, it should touch the back of your teeth and do a wave. Some kids never learned that, and so they do this. And so that pushes those teeth out. And so a lot of kids have to get braces multiple times because the tongue are putting so much pressure on those teeth that it's pushing the teeth out. And so those kids that get multiple braces or don't have lips closed nasal breathing have to get braces again because the lip isn't acting like a retainer for the teeth. So the teeth get pushed out because the lips aren't holding the teeth in. So I've had the parents have come in and the kid's 15 and it's like, well, he's had 5 sets of braces. And it's like, well, yes, because this is his position at all times. So he can't keep his lips closed to keep those teeth retained. And so that was why. But he talked like this, like I heard like he would never use this lip. So in a nutshell, that's what orofacial myology is. It's looking at breathing posture, resting tongue position, and how that affects swallow and speech, as well as sleep apnea, and all of those things. Because if you don't sleep nasal breathing, your body actually fights more to breathe. And so a lot of those kids can't have a restful sleep at night. And so they wake up not rested. And so they act like almost they have ADHD because their brain's trying to stay awake. You can't really have rest and recovery sleeping if you can't nasal breathe and truly rest. And so they're having a harder time retaining information and they have a hard time sitting still because their brain's just trying to stay awake.
Wow.
Fascinating.
I mean, that's a lot. But
Yeah. No. Wow, in a good way. So I'm just going to recap real quick.
yeah, I know I
Actually,
throw a
that's
lot of
probably
stuff out there. Sorry.
No, it's good. No, it's good. But one piece you just said that I want to restate so it doesn't get lost or it gets emphasized. So you're saying that a lack of sleep can look like ADHD. So kids that are out there diagnosed with ADHD could actually have sleep apnea or some type of sleep disordered breathing.
Yes.
So
yes. So even though the parents will say, well, they slept 12 hours, but it wasn't a good quality sleep. because they shouldn't
Right.
need that. And then so what I'll tell them parents is go in and look, are they mouth breathing? Do they snore? Because if they're mouth breathing or snoring, that's a clue that they're not getting nasal breathing, full diaphragmatic,
Hmm.
restful sleep. So their brain is fighting and their heart's everything's working really hard to try to sleep. And then that's those kids that have like bedwetters too. It's because their
Mhm.
brain wakes up. And so then their body thinks, okay, I have to go pee. And so then they wet their bed versus truly, and not every kid, but a lot of kids that have bedwetting, it's just because the brain is like where they have a hard time staying in REM. And so when they come out
Yeah.
of that, they can bedwet. So,
Mhm.
but definitely I've had parents that the kids come out that are mouth breathing and I say, you have to go get adenoids and tonsils looked at. And they do it. And then they do not have those ADHD symptoms anymore because they're actually getting restful sleep and they're not sleeping 12 hours. They can sleep 8 and then they're able to have a more functional day and retain information and the behaviors and the aggression. Because when they're not sleeping, like all of that helps calm down with awareness. Yeah.
Yeah. Well, I know how I feel when I don't sleep. And that's just lack of sleep. I don't have sleep apnea that I don't think, but just lack of sleep in general, yeah, just makes me grouchy. And I just want to say one thing too. I love that you brought up snoring because how normalized is snoring in this society? If you tell
Mhm.
anyone, oh, let's pretend we're going to sleep, what do? You pretend you put your head on your pretend pillow and you start snoring, right? That's what sleeping looks like.
Yeah.
And I don't think people realize that snoring is not okay.
Right.
And you
Just
shouldn't
because
have
it's
any
normal.
resistance. Right.
Yeah.
It's
Just
not
because it's
normal. Yeah.
normal doesn't mean it's okay.
My question to you then, Kel, is because you say you love working with babies.
I do.
So, what is it then when you get the referral for a baby to come in? What is it that either the parents are seeing, the doctor's seeing that's referring them out to you to begin with? Because you were saying you would rather like start with babies and then make sure that everything is in place, functioning correctly before getting somebody who's like 13 or 15 into your clinic. So, what are some of those red flags that we should be looking for early on from being a baby, like firstborn?
So if they cannot breastfeed, that there's a reason. So instead of band-aiding the problem with the bottle, figuring out why they can't breastfeed. Because many times moms will say, well, I didn't make enough milk. Well, it's not mom's fault that she didn't make enough milk. The baby wasn't sucking correctly, so the mom's milk wasn't produced enough. So looking at it from that aspect, also babies that come in that are mouth breathers from the very beginning. So mouth is open, tongue is down. So already we're seeing that palate getting higher and higher. So now getting that tongue up there. It could be because of a tongue tie, although I think some tongue ties are over diagnosed. So I like to see what we can do to address it before that. But if it's not a tongue tie, if it's truly oral function, working on getting that tongue up in the palate so that the palate can re-expand. And then I also am looking at those primitive reflexes of like lateralization, because I was seeing kids come in at 2 who are super picky eaters, but when I go to put something in their mouth, their tongue isn't lateralizing. And you should put the food in your mouth and move your tongue to the molars so you can chew. Some kids never cannot have that reflex to move left and right. So they don't want to eat solids because all they do is put it on their tongue, mash it to the roof of their mouth and swallow and then gag and then spit it out. They never learned that reflex. So looking at the jaw strength, because the jaw is the core of the mouth. Just like if your core is weak, you can't
Mm-hmm.
lift your arms, you can't hold your head up. So if the jaw is stable, then the tongue can do its job, the lips can do its job, everything can do its job. So checking on bottles, any feeding should only take 10 to 15 minutes. So a red flag to me is anything longer than 10 to 15 minutes every 2 to 3 hours tells
Mm-hmm.
me that there's some kind of oral dysfunction in a baby. Also, the mouth breathing, tongue down is an oral dysfunction. Like we need to fix that. The nasal breathing. So those are the big ones that I see. I do look for the ties, but sometimes it's just tension from torticollis or something. It's not a tie. So again, I don't always jump right to, oh, it's a tie, because parents will sometimes go get a tongue tie release, and that wasn't the issue, or that wasn't like the root of the problem. It was part of it, but it wasn't really the problem. So I like to address the dysfunction first so that they're not going through the every 3 hours for 2 week stretches when really that wasn't helping that part, the dysfunction. Makes sense? So
Sure.
yeah. So those are like the big things I look for.
So, what then for a newborn, what is keeping them from keeping their tongue at the roof of their mouth when obviously they're not aware of what they're not aware of? Does that
Right.
question make sense? Yeah.
Yeah.
So, what would be
So
some other contributing factors that they are already being born and breathing with an open mouth?
So it could have been coming out of the womb if anything happened. So like scaphocephaly or brachycephaly, that can change the formation and the tension in the neck, which again can pull that mouth open. It also can affect the tongue movement because if everything's tight and tense, the tongue can't move. And again, the more the tongue is down, even in the womb, the tongue isn't resting up here. So they come out with an inability to rest their tongue in the palate. The palate might already be high, or any kind of trauma could cause, or tension in the womb causing torticollis, that can pull on the tongue too. So that's kind of where that comes into play. Also, a lot of pacifier use. The pacifier becomes that spot, so the tongue can't get up to the palate. It's almost like a pacifier palate, not a tongue palate. So I always tell moms, like, pacifiers are fine, but within reason. You got to pop that pacifier out and get that tongue up there, so that the palate can know, okay, I'm supposed to be wide. I'm not supposed to be small and narrow.
Yeah.
Got it. And I'm just going to backtrack just a little bit because I think Lori and I both understand tongue ties, but our listeners may have never heard the term or know what that is. Can you just describe what a tongue tie is and how, how that impacts everything in terms of swallowing and oral function?
So in the womb, the tongue starts like this, and then it should move back so that when you lift up your tongue, you see that little string that's underneath the tongue. Sometimes the tongue that string doesn't move back far enough. And so it's called a tie, because sometimes you see those kids and they lift up their tongue and it's like almost like a heart shape because it's all being pulled, like the tongue is being tied or pulled. Sometimes there's mixed feelings about a posterior tie, and that's why sometimes it truly is just tightness and like fascia tightness. Sometimes it really is tight, and so they can't lift their tongue up. So when they try to touch the roof of their mouth, they can't get it up there because the tongue is being held down. So you can sometimes get little red flags of spots, or it looks like things are being held down. So a lot of doctors just see an anterior, which is all the way to the tip of the tongue, and they just release that one little piece so that their tongue can actually lift up. But I've had 12-year-olds come in with it all the way to the tip, and the dentist never said a word, and the kid can't talk very well and is picky. Well, yeah, because there's no
Right.
movement of your tongue.
Their
So
tongue is tethered down to the floor of
yeah,
their
it's
mouth.
literally being sucked down and held down. So there are different specialists around. I would say if a parent doesn't know what it is or what to look for, not all dentists know, not all ENTs or pediatricians know or think it's a thing. So if they're worried about it, you could kind of Dr. Google, but not too crazy Dr. Google, and get a couple opinions before you just say, okay, I'm going to do this. And I would definitely do some speech therapy before you do the release, so that the muscles know what it can do, so that once it's released, it kind of has an idea of what to do, versus releasing and then the tongue's like, I've never moved. I don't know what I'm supposed to do now. So
Mm-hmm.
I always say to the parent, like, we just want to work on getting the tongue muscles to know I need to go left and right, but I can't. So once the release is, then there's actual movement versus now there's even more muscle and you still don't know what to do with it, kind of a thing.
Mm-hmm. Mm-hmm.
So, Kel, if somebody is still picky at 13 years old, like a picky eater at 13 years old, could there be an oral issue there?
Yeah.
Fascinating.
Yeah.
Can I
Yeah.
share a personal story? I have two actually. So I had a tongue tie, and I only knew that I had a tongue tie because I took classes in myofunctional therapy. And I was like, oh, so you mean to tell me that my tongue should not be folded in my mouth? So instead of my tongue laying flat in my mouth against like my palate, my tongue was like this. It was literally folded in half in my mouth. I had braces. My dentist gave me a mouth guard with this little nub on it to prevent my tongue from touching it. Well, no, there was not enough room in my mouth for my tongue. Tension in my neck, all sorts of stuff. So at the age of 42, I had a tongue tie release, and guess what? It now perfectly lays on the roof of my mouth. Surprise!
That's
There we go. It's where it's supposed to
crazy.
be. But all the years went by and no one ever brought it up. I figured it out on my own just because I took the class. And then the other story I have is my son. So, because of all of that, when my son was born, and I've shared this in other podcasts, but the 43 hours of labor, 4 hours of pushing, all that trauma you talked about, my child had. And they put him on my chest, and I look at him and he's crying. And my first thought is, I think he might have a tongue tie. And then they put him on to nurse. Painful as hell. So, and let's just say that too. Can we just put the disclaimer out there? Breastfeeding shouldn't hurt.
Yeah.
If it hurts, something's wrong.
Right.
I had 3 lactation consultants helping me, and all of them did not mention anything about it shouldn't hurt. It shouldn't hurt. Oh, you're doing fine. You're doing fine. I'm like, my kid is, I don't even want to get into the details, but it's, everything was sore. I was crying while breastfeeding, and I'm like, this can't be normal. This can't be normal.
Mm-hmm.
So had the tongue tie released, and it took a while. It took him 10 weeks to finally feel healed enough to be able to nurse properly. And then he could, and he did, and it was fine, and it didn't hurt at all.
Oh, that's
So
good.
I know. So
Yeah.
the point is, yeah, trust your body, trust your instincts, and just like you said, get more than one opinion because not everyone knows all the things. So,
Right.
yeah.
I know. I just always come back because we had just done a podcast a couple months ago, Kel, with a pediatric occupational therapist and talking about primitive reflexes. And again, the conversation always comes up of how do our pediatricians not know this stuff? This is how I'm feeling with what you're describing, which again, why we have this podcast and this platform is to educate parents to just know what to look for. Not that you have to know how to go about treat it, but being educated and knowing what is normal, what is not normal. When you see not normal, then going and finding the practitioners who believe you.
Yeah.
Right.
Because,
Yeah.
right? But I'm just always in awe of what, and I always come back to the pediatricians, not to beat them up, but I'm just always in, because they are supposed to be our main source, right? I mean, they're who we take the baby to right after we're done giving birth, and we're with that same doctor for how many, years. And so I'm always in awe of what they don't know.
Yeah.
I really
Well, and
am.
I always
Yes.
say they have to know a little bit about a lot of things. So I
Right.
get it. But then don't say, like, nah, it's not a thing. It's like maybe say if the parent's concerned, maybe say, well, let me send you to somebody who's more knowledgeable in this area because you can't know everything. So
No.
I wish the pediatricians would say, like, I'm not seeing it, but let's get one opinion on
Right.
that. They do that for pulmonology or neurology. Why don't they do that for speech or feeding or occupational therapy?
Yeah. Yeah. And I'm going to add in
But I
pelvic
don't
floor
even
physical
think they
therapy to
know.
that too.
Right. But do they even know to do that? That's the thing. Like, I would not know about any of this if I had not taken the coursework. I'd have no idea. I wouldn't even know where to look. Facebook groups save my life so many times since I became a parent. Really. And even like the tongue tie groups. And if you're looking for a knowledgeable provider, word of mouth is huge. So they
Mhm.
have tongue tie groups for every state,
They
where
do.
you can just, right. So that helped me a lot anyway. Because I
Yeah.
live
Well,
out
it's
where,
it's moms going out and asking the questions, right? And then
right.
having people respond who is currently walking that path or have had that experience. And yeah, the mom train, man, it's the best one out there in my opinion. But yeah, it would just be nice to have like somewhat of a general checklist that your pediatricians kind of go through. With even just those two basic questions like you were saying, Kel, it's the baby mouth breathing and how's feeding going? Just something to get the conversation going so that this we're not stuck there thinking that we're the problem, that
Yeah.
we're not making enough of milk or I'm stressed, because we are the first to put the blame on ourselves. We
Mm-hmm.
Yeah.
definitely are. I
Yeah.
know.
Mom
Oh my,
guilt is real for sure.
mom
Yeah.
guilt is real.
Yeah.
Yes. So here we are sharing with our individuals who are the most experienced to give you guys all of this amazing information. But so Cal, okay, so you ideally would like to get them in as babies if there's issues. But let's just say that doesn't happen. What are some other red flags that parents could be looking for as the child is aging that other problems may be starting to now come up, other than, say, the mouth breathing and obviously the trouble latching, because they're going to eventually outgrow that. So, as they're getting older, what are those things? You already mentioned like multiple sets of braces.
Right. So definitely, like I said, the mouth breathing, having mouth closed, sleep. The sleep is a big one, and the snoring. Like those are the big ones because
Mm-hmm.
all of that literally changes the structure of their face and their skull and their jaw. I would say too, if they're picky eaters past that age of 2.5, because what are they eating? Are they eating a variety of foods? They just don't like broccoli. Okay, fine. But are they still eating processed foods? Because processed foods take no chewing, minimal jaw strength. They don't want to eat steak because it takes a lot of chewing versus a chicken nugget's been ground up, put back together. So
Mm-hmm.
it's just a little bit of chewing and then they can swallow it. So looking at those variety of foods and the textures of the foods and why are they not eating some of those foods. And they always say, and this is totally off topic, but because we're talking about this really fast, I tell parents just because you gave the kid broccoli 3 times and they won't eat it, it might take them 20 times of seeing it on their plate before they'll try it. And then it might take them, they say 15 times of putting it in their mouth and exploring it and being open to, okay, that was weird before, but I'm getting more used to it and now I'm okay with it. So really after they say like 15 times, if you're on the spectrum, it's even longer, but you
Mm-hmm.
can't just say, I gave it to them twice, they don't like it, and then never offer it to them again. Just put a little bit in front of them on their plate or right off their plate, but near them. So if they want to explore it, but it's not the pressure. Also, never pressure your kids. But this is a whole different topic. I'm sorry. But that is a
No, this is
red,
No,
good.
it's
those are,
This is
important.
good.
that's a
This is
red
Yeah,
good.
it's
flag
good.
too, is the variety of foods, the textures of the foods, as well as sleep patterns, behaviors, all those kinds of things, and lack of sleep or too much sleep. Really, it's not, because that's a red flag. And the nasal breathing. I mean, all those are the real big ones that I look at when I'm talking to a family.
Mm-hmm. Is that why so many kids like chicken nuggets? Like you
Yeah, I mean,
just
they're
use that
super
as an
easy.
example. And I'm like, is that why? Like so many kids love chicken nuggets. Oh my
Well,
God.
they
Now I'm going to
say
be
the
looking at kids who order chicken nuggets and I'm going to be like, oh, let me watch how you, yeah, the joke is, Kel, like obviously as I continue to learn things, I'm always like out there, just, it's the therapist in us scanning and observing, and I'm like kids that aren't even mine. I'm like, oh, okay. I wonder if blah, blah, blah. So now they're going to be ordering chicken nuggets. I'm going to be like, I'm going to watch your posture as you're eating. No.
I was going to say you could keep a stack of Kelly's business cards in your back
Yes.
pocket and just like slide it on their
Yeah,
table. Here you go. You might want to call
exactly.
her. She can help.
Exactly. She can help. No, isn't it fascinating though? I mean, the most basic thing, and it's right there in front of you that could be giving you a clue. It's just,
Yeah,
yeah.
it's that white yellow diet that they say, because kids that are picky, potatoes are really easy to eat and they're white. Chicken nuggets
Yeah.
are easy to eat and they're white and yellow. Like pancakes, some cereal, like it's all
Yeah.
that easy to eat versus stuff that really you have to like bite and tear and chew. and really
Right.
work on it, that tells me jaw weakness. So if they have a mouth breather and there's jaw weakness, then there's a lot of stuff going on there. Probably their speech is not amazing because their tongue doesn't have that variability of movement. And how do you have good variability of movement without stability from the jaw? So it all works together in a lot of different ways, which is why I like occupational biology. I just think it's that bigger picture, you know?
Yeah, it's fascinating. It is fascinating. So let's then dive into like the treatment piece. So you have again a kid come in and you need to get into correcting these issues. So what does a treatment look like for a parent, Kel, and how long?
So it depends on how much they're doing at home for carryover follow through, right? But really, the big thing you're going to start working on is if they can do mouth closure, nasal breathe. That's a big, just listening when they do nasal breathe. Do you hear that audible like restriction in their nose? And if they do, then I say you need to go to an ENT really before we can even work on nasal breathing. Because if we're saying you have to breathe through your nose and they can't, then that's not going to be great. So another simple thing we would do would be clicks of the tongue, getting that tongue up to the palate because that'll strengthen the tongue because of that restriction of popping it down. And if they can't do it, then that would be homework assignment, is just getting those really big clicks, because the goal is the tongue should rest up in the palate and the tongue has to have the strength and ability to get up there. So that's something super simple. And then that disassociation of the tongue. So watching the tongue be able to go left to right without it going
Right.
like the whole jaw movement, like stabilize the jaw and then do the movement without the whole jaw helping everything out. So those are like super simple things that you would do for therapy just to start there, because then you want to work eventually on getting that tongue up here to swallow versus that thrust swallow. You want to get that tongue. Well, another one would be tip to spot, right? So putting that tongue right behind on that little ledge right behind your teeth and just holding your tongue there while you open and close your jaw, because kids can't do that. You'll see their tongue come forward. So instead of holding it here, their tongue will do this because they don't have the base of the, like the back of the tongue isn't strong enough to stabilize. So just the tip is moving. So stabilizing is another strategy. So you have to stabilize so that you're not getting that lisp or that thrust swallow by just doing tip. So those are kind of like the baseline starter things that we would work on for therapy, but really seeing
And
airway first.
that makes sense. And I'm wondering, allergists too, do you ever recommend allergy testing, like, for stuffy noses?
Yeah, well, I would first do ENT, and if the ENT or I also say sometimes go to an orthodontist and get a 3D topography of their airway, because you can see literally 3D if they have enlarged adenoids or tonsils in the 3D topography. Without, if you can't get into an ENT, if an ENT is 6 months away, find an orthodontist or a pediatric dentist who can do a 3D topography for you, consult. And then you have this picture, and then okay, well, I know now I need to go to an ENT, or no, the airway is good. It's not that. So then you could do allergist next.
Yeah,
So
makes
I
sense.
an easier time to get into an orthodontist or a dentist, usually faster than an ENT, if we can't see that tonsils are enlarged by looking in, because sometimes you can't even see in there because the airway is so small and tiny, you can't get in there and see. But the
Yeah, that
picture
makes sense.
tells 1,000 words, right?
Yeah,
Kelley,
fascinating.
do you notice that does this ever happen where you work on the strengthening exercises and the disassociation and all of that, and then speech just gets better? Or do you still have to work on speech afterwards? I'm just wondering, if you're getting the tongue functioning correctly, does speech just like start sounding better after on its
I
own?
mean, it can to a point. I mean, even ours, like if your base of your tongue is stronger, now you can get your tongue up to make an R. But then you're changing a habit. You're not changing the function. So once their tongue can do it, then you're just teaching them the habit of no, you make an R like this. You don't make an R like you have for the last 12 years. So just teaching them the habit, but the speed is faster in recovery because now you know an S, you don't have your tongue out for an S. Your S has to stabilize with your tongue cupped. Or the R, it goes back, right? It retracts instead of kind of
Mhm.
being flat. So it's more of a habit changing, which is a faster
Yep.
speech
Mhm.
recovery. Yeah.
That makes sense. So I know that R is a super hard one, and sometimes there's kids in high school that still can't say R. Is that also a red flag? Like if you're someone that you've been in speech therapy for years and years and years, and you're still working on your sound, get evaluated by a myofunctional therapist to see if there's other things going on.
Yeah, I think that would be a good
Yeah,
idea. Yeah,
yeah,
I would say
yeah.
find that person. But yeah, for the S and the R for sure.
Hmm.
Because and also looking at the palate, seeing if the palate is high, because if it's high, it might not be able to get up there, or looking for a tongue tie, which a myofunctional therapist should know how to look
Hmm.
for that as well, even though there's issues back and forth on it, can they diagnose it or not, but they could see, is there restrictions there that could be holding it away. But definitely myofunctional therapy for multiple sets of braces. There's a reason, and for those S's and R's, there's a reason. Because the orthodontists aren't going to usually say, unless they know a myofunctional therapist. Orthodontists aren't going to say like, "Oh, well, I'm going to put a third set of braces on, but maybe you need to go see a myofunctional." They're going to say like, "Okay, well, come on back." They want the
Yeah,
money. So it's sometimes there's that partnership with dentists and orthodontists, but it's not always the case.
yeah.
Mhm.
And I'm just going to put this out there that depending on where you live, your dentist might not know what a myofunctional therapist is.
Right.
Where I live, they are hard to find.
Okay.
So the skill set is very different depending on where you live. So they just might not know it's even a thing.
Yeah,
Yeah.
and you could type in IOM, myofunctional therapist, and there are some RDHs that, which is dental hygienists that have
Hmm.
myofunctional training. So it could be if you can find a dentist that has an RDH that has a myofunctional training. So you could type in myofunctional therapist near me, kind of a thing, maybe,
Hmm.
and see
Hmm.
where they are. I
Yeah.
don't, there are ones that'll say, pay me $3,000 and we'll do teletherapy for 10 sessions online and they'll never meet you in person. I don't like that because
Yeah.
they're not able to see in your mouth to
Yeah.
really know. Like
Mhm.
I'm okay if it's like an evaluation in person and then you do teletherapy. And there's a lot of specialists out there now that are not speech therapists or RDHs that have myofunctional training, but they don't have the background. So I'm a little like, I don't love that either. I think you should have the medical background to really see that bigger picture for the best therapy
Mhm.
possible. But if
Hmm.
you can't find anybody else and that's who you can find, I would be careful to pay that $3,000 for services unless you really know what's going on there.
Hmm.
Um,
Mhm.
you know, but
Yeah.
Yeah.
Makes sense.
That totally makes sense. Well, and not every speech pathologist does myofunctional therapy either,
correct
right? So
for
let's,
sure.
yeah, yes. So,
Yeah.
I mean, sometimes it might be a good place to start. You could also ask a speech therapist, do you know of? Because
Right,
hopefully some kind of connection and they would obviously believe in that path. I would hope so. But yeah, it doesn't mean that they actually do it. That's the
right.
other
Hmm.
thing. But myofunctional therapist is where people can start searching. Just that term
Yes.
alone, Cal? Okay.
Yeah.
Okay, that's good
Yeah.
to know.
Yeah.
I know. Oh my gosh. My girls are 13 and I'm still learning stuff. Like that's what's so fascinating about this. And so I'm like, okay, they were never picky eaters. Like I'm going through my head in all of this of okay, I think we did dodge that bullet. Some others we have not dodged, but I think we're okay from a myofunctional standpoint. Yeah. It's my
I
husband
am
who
still working on, oh yeah, your husband, go ahead and then
oh
I'll say
yeah.
my thing.
Oh no, I was just
Hmm.
gonna say, I think my husband needs the myofunctional therapist out of everybody. My tongue is
Yeah.
like I'm good. I'm not a snorer. I like my tongue rests at the roof of my mouth. Yeah, I'm pretty good in that department.
But who would ever think? It's just one of those things. Like, why would you ever think that your tongue would be in the wrong spot?
I know.
Right, right. You're
Yes.
just going about your day, and all of a sudden you realize your tongue shouldn't be hanging out at the bottom of your mouth or curled up like mine. Who knew?
I know. I know. I'm blown away that your tongue was curled, Dorothy.
Uh-huh. It was curled in half. And my dentist is like, that's okay. We can fix it. I can make you this appliance you can wear at night, and it will train your tongue not to touch the
But
back
it's
of
not
your
like
teeth.
you didn't talk funny. You didn't like say words funny.
No, no,
I would think
no.
that that would have
I was
happened.
just compensating. But I did and still do have a
Yeah.
lot of jaw tension. A
Mm-hmm.
lot. I mean, part of it is being a parent.
You're
This
clenching.
is just where
Yeah.
it likes to hang out. But yeah, I mean, there were signs, but you just don't know. And again, it's all normalized. It's right. How do you not?
Mm-hmm.
When do we ever have a conversation like Lori? I've known you for how both of you I've known for a long,
Yeah.
we met at the same time. But Lori, we've been like
Mm-hmm.
talking daily for what, 15 years? Oh God, how long
Oh
has it
God,
been?
over 20 some, I think. We've lost
Yeah,
track.
20 years. I don't know.
A long
When would we ever be like, hey, Lord, where's your tongue hanging out in your mouth? Can you?
time. And you
By
know
the
what?
way, fun fact about me, my tongue is folded in half in my mouth.
But
You bet you
here's
didn't know
the
that.
funny thing. We would have talked like that. Like that's so a
I know.
conversation that we would normally have. That's the
It's
reality of
true.
all of this. But you know what? I know. And well, I kind of like joke like, okay, with the pelvic floor, you don't see it until you feel something that there's a problem, right? And your tongue, you get to see that. But still, we're not taught of like what's normal and what's not normal.
No.
It really blows my mind. And then we focus then on other treatments and wonder why they're not as successful because we're
All
missing
right.
the true problem, right?
The root cause. Yeah.
Mm-hmm. Root cause.
Yeah, it's always that looking for that why. You know what I mean? It's like, let's not band aid it. Let's figure out the why. And if
Mm-hmm.
we need that compensation strategy to, in the meantime, while we get where we need to go, but let's not band aid it and then not address the why.
Yeah.
So trying to get these doctors to understand that and then the parents to advocate for themselves to these doctors and say, this is what I want and this is what I'm not okay with. And so you need to just give me the referral or make it happen, kind of a thing.
Right.
Good point. And to also be prepared potentially for pushback and be okay with that, because doctors think sometimes I've come into situations where the doctor just doesn't like to be questioned, and you have to feel okay and empowered to stand in your power and just to advocate for what you need. I remember
Mm-hmm.
when my son was 2, I went to an ENT. I found a quote good one. We went for an exam. There's no way he would have tolerated a scope at that age. And nobody talked about any type of x ray or anything. But he looked inside my son's mouth and said, his tonsils are fine. Therefore, there is no possible way his adenoids could be enlarged. There's no possible way. Let me tell you, it is possible. And my kid's tonsils were 95% enlarged when we finally did get an x ray, and then he had surgery or whatever. But there he was arguing with me. There's no way. No, there's no way.
Mm-hmm.
You're wrong.
And that
And this
my
poor
older
kid, yeah,
Yeah.
go
And
ahead.
my older one, the doctor, same thing. She was chronically stuffy, but nothing would ever come out. And I said to the pediatrician, I think we need to have her adenoids and tonsils looked at. And he kept saying, well, she didn't have enough strep. She's not strep. It's not strep. And it's like, but that's not, it's that
Yeah.
she cannot breathe. Like she literally always sounds stuffy. And so they went in
Mm-hmm.
and took her adenoids and tonsils out because they were big. And so it's like the doctor was like, no, no, no. And I said, no, I am going to an ENT. I am having this looked at because this is what I'm feeling and seeing, and I'm gonna dismiss you and go to the
Yeah.
ENT. So again, mom's gut and just following
Mm-hmm.
that intuition. And if one doctor says no, find a couple more or find a different pediatrician if you get constant pushback.
Totally.
But
Totally.
um,
Mm-hmm.
but yeah, kids
Mm-hmm.
got to breathe. They have to breathe in
Yes.
order to grow and thrive and
Right.
learn and
Yes.
all the things. So breathing's a big
Yes.
one.
Yes, it
Yeah.
is.
And my child, we actually went in twice for surgery. The second time, we realized that his lingual tonsils were enlarged, which is something we had to really, I didn't even know there were lingual tonsils, to be honest, until I'd been down the rabbit hole of Facebook and professional airway groups and whatever. Then I'm like, wait a minute, this sounds like my kid. And lo and behold, they found that his lingual tonsils were gigantic. So adenoids were okay. Palatine tonsils were okay, but lingual tonsils were huge, so he still couldn't breathe. So point being, there's multiple points in the airway that could be obstructed, and it might be more than just, right, adenoids.
Or
And
enlarged turbinates too. Like if your turbinates are
yes,
enlarged, then you're chronically stuffy because they're inflamed. They just have to be like ablated so they get opened up. But it's not the adenoids, it's the turbinates in the nose that can also be inflamed.
What's a turbinate?
It's almost just the channels in the nose up higher. If they're inflamed or too small, then not enough air. So, I mean, a big thing would be to have your kid close their mouth and breathe through their nose for 3 minutes. If you can hear it audibly, there's some restriction that's causing a problem, whether it's adenoids, turbinates, or something. So that's like a simple test that you can do is just listen to them breathe with their mouth closed when they're not
yeah,
stuffy
great
because of
tip.
allergies or whatever. But
Yeah.
that's
Yeah.
just a super simple thing you can do.
Yeah, great
Fascinating.
tip.
Great tip. Oh my gosh. Well, ladies, as we wrap up here, is there any other final words, Kel, you want to add to this? Or is there any good resources we could turn people to? I, of course, am going to put your information for the Speakeasy clinics in our show notes. But any other pointers to give our listeners?
There's so many books and podcasts and stuff too about pediatric breathing or nasal breathing or all the things. Just and there's even myofunctional podcasts and stuff out there too. So I would just say look at pediatric picky feeding. There's things. Look at myofunctional podcasts or there's tons and tons of books about sleep disorder breathing for pediatrics. There's tons of books on breathing just in general for adults that can be applicable for kids. So as the world grows and there's more things online, there are a ton of resources out there, but don't go too far down the rabbit hole. Ask the questions. Don't pay $3,000 for an eval and treatment. I would say talk to somebody in person, then decide if you want to go that route. But they can say, there's appliances for $3,000 too. And it's like, yeah, but is that really necessary? So don't jump too far in, like take it easy, but definitely look for those red flags. And then if you see them, ask the right people, or people can email me through the website or whatever too and ask me questions. I'm not going to not answer a question because you're not my client. If I can help guide or give resources, I'm happy to do that because our job is to help people in general, not just to help my people in Las Vegas, you know? So,
Yeah. Yeah. Well,
so yeah.
thank you. No, that makes sense. Well, I think the biggest takeaway for people from today, at least for me, because this is not my area of expertise, is one, knowing the red flags that you went through, and then knowing that there is treatment for this, which comes from working, whether it be fascially on the muscles, releasing tension, and or then strengthening the whole oral motor complex. And to
Yeah.
your point, Kelly, like you were saying, like sometimes you have to use compensation or devices, but that should not be the total fix. If somebody just wants to put you your second, your third, fourth, fifth set of braces, right? Red flag, red flag, red flag. So just know that there is treatment for this and that we don't have to keep doing those band-aid fixes.
Right.
Yeah. And then we wonder why we're seeing behavioral stuff or grumpy, grouchy kids or not paying attention and stuff in school because they're probably not breathing right and they're tired and they're exhausted. Right?
Yeah, for sure.
Oh my gosh. Well, this was amazing. Do you have any other final comments,
No,
questions
I
for
think I've
Kel?
said it all. My big thing is reach out to your community. If you can't find a myofunctional therapist or a good ENT or you don't know where to go, there's probably someone that lives in your community that's going through the same thing. So reach out and ask questions because that might save you a lot of time and energy and it'll give you support. That person can be like, this is what I've gone through. Don't go to that person. This person's better. This is what I'm experiencing. Because when you're navigating this, it's very easy to feel overwhelmed and alone in all of it, and you're not.
Mm-hmm.
And
Yeah.
and if you can't find anybody, call Kelley.
Call
She'll
Kelley.
help you. We're here for you.
We're here
We're
for
here for
you.
you. You're not alone. We're here for you.
Oh my gosh, wonderful. Well, again, always good stuff. We could keep talking for hours. Kel, I'm sure we can have you back on and we could talk about a whole bunch of other stuff as well. You are a wealth of information, and thank you for coming on and taking time out of your busy clinics to help us spread the word to all the moms and women listening out there. So thank you.
Yeah. Yeah, of course. It's good to see you girls.
Yes. All right,
Thank you.
everybody. We'll see you guys on the other side. Take care.
Okay, bye.
The information shared on this podcast is for informational purposes only and is based on the opinions and experience of Lori, Dorothy, and their guests. The content should not be used as a substitute for professional medical advice, diagnosis, or a treatment. Always seek the advice of your healthcare provider with any questions you may have regarding a medical condition. Never disregard professional medical advice or delay in seeking it because of something you heard on this podcast.